Assalamualaikum warahmatullahi wabarakatuh. Excellency to all of the judges and unforgettable to all of the audience whom I love. Since being first discovered in 1982 by the CDC, the distribution of human immunodeficiency virus infection has reached a global scale. Based on a study conducted by WHO in Southeast Asia region, out of the 110,000 children suffering from HIV infection, and only below 50% got a treatment. It is known that 90% of pediatric HIV is caused by mother-to-child transmission. HIV is a blood-borne virus typically transmitted via sexual intercourse, shared intravenous drugs, and mother-to-child transmission which can occur during the childbirth process or breastfeeding, and thus causing immunodeficiency or AIDS in the end. When becoming immunocompromised, several clinical manifestations will occur due to opportunistic infections such as tuberculosis, fungal infection, persistent diarrhea, or even uncommon parasites such as toxoplasma infection, which leads to severe morbidity and even mortality to the patient if not managed properly. So here, I, Ievan Hakim, going to present an uncommon cause of status epilepticus and loss of consciousness in a child with a human immunodeficiency virus suffering from tuberculosis, meningoencephalitis, and cerebral toxoplasmosis. A 6-year-old Indonesian girl was referred to the emergency department of Saiful Anwar General Hospital, Malang, from Jombang General Hospital with episodes of seizure followed by loss of consciousness. Before being referred to Saiful Anwar, the patient underwent episodes of seizure for as many as 4 times, with each episode being at least 5 minutes, with clinical manifestations eyes rolling upward and stiffness of both upper and lower extremity. The patient suffers from constant headache 2 weeks before being brought to Jombang General Hospital, followed by a projectile vomit 3 days before entering hospital. After being treated 3 days in the Jombang, the patient observed consistent asymmetrical eye movement and also right hemiparesis. It is known that from the age of 2 months, the patient was hospitalized frequently in Mojowarno Hospital with a constant chief complaints, namely diarrhea, cough, cold, apnea, and push-feel wounds on the head. However, the patient doesn't know the diagnosis of the disease. After reaching 3 years old, the patient rarely suffers from any sickness and has never been hospitalized until December 2018. Worried of her this condition, the aunt initiated HIV screening to be done, and the result came out to be HIV positive. It is known that the patient lives in a broken household. The biological father of the patient died of unknown cause when the patient was 4 months old and the biological mother ran away from home. The patient was born with a normal condition and then raised by her aunt and uncle from 2 months, with the consumption history of patient from 6 months was good, but with low nutritional contents due to economic condition. And the immunization history, as seen here, is good. In Jombang General Hospital, effort to treat the patient's condition was done, but the patient's condition didn't improve, thus referred to Saiful Anwar General Hospital with status epilepticus followed by loss of consciousness as the main issue. Upon arriving in the Saiful Anwar General Emergency Department, a quick physical examination was done and the result can be seen here. After that, the patient were given phenytoin for 20 mg per kilogram body weight intravenously for 30 minutes, followed by a prescription of phenytoin 8 mg per kilogram body weight for every dose to be given daily, and a dose of diazepam 0.3 mg per kilogram body weight for every episode of seizure. After the seizure was handled, further workup was requested. And the result of the complete blood count shows a slight abnormality in the hemoglobin levels. Different cell count reveals a high number of monocytes. The blood chemistry indicates hyponatremia and a slightly low amount of ureum. Its HIV rapid test indicates reactivity in all 3 tests, which confirm that the patient is HIV positive. CD4 count is very low, 18 cells per microliter. Abnormally high level of toxoplasma IgG and IgM is found indicating present infection of toxoplasma. This is supported by GSF analysis with an increase in protein, a decrease in glucose level accompanied by the decrease in LDL level, and mononuclear cells are found within the CSF as much as 92%. Based on the complaints and the laboratory examination, the patient is suspected as having a TB meningoencephalitis. The CT scan shows an enhancing cystic lesion, thin wall in the subcortical lobe of the right frontal and parietal lobe with a multiple in the subcortical lobe of left temporal parietal lobe, accompanied by extensive peripheral edema that forces the left lateral ventricle and causes a midline shift as far as 0.9 cm to the right. The cerebral toxoplasmosis and tuberculosis is suspected. After the emergency condition was handled, the patient was hospitalized in a pediatric high care unit with a diagnosis of stage 4 HIV, followed by tuberculosis, meningoencephalitis, and cerebral toxoplasmosis co-infection. The patient receives the management of TB meningoencephalitis in the form of intramuscular injection of streptomycin 20 mg per kilogram body weight per day for 2 months, followed by oral intensive FDC for 2 months, and continued past FDC therapy for 10 months. Ethambutol 20 mg per kilogram body weight per day for 2 months, oral prednisone 2 mg per kilogram body weight per day for 4 weeks, and the oral pyridoxine with a dose of 1 tablet per day. On the management of cerebral toxoplasmosis, patient received treatment in the form of oral clindamycin 20 mg per kilogram body weight and oral primetamine 1 mg per kilogram body weight for 6 months. Patients start receiving first-line ARV 2 months after the treatment of TB meningoencephalitis until March 2019. The ARV given were zidovudine, lamivudine, nevirapine. After 12 days of intensive treatment, the patient was discharged and outpatient treatment is initiated, where the patient returns to the outpatient department every month for check-up regarding the patient's condition. The table below shows the patient progress for 6 months and being hospitalized in SIK with a very good patient improvement proven by a control CD4 plus and the restoration of patient activity. Okay, we're jumping to the discussion. As we know that HIV/AIDS still become a global concern because it is highly spreadable and causing high morbidity and mortality, including on a pediatric basis. Rapid diagnosis and proper treatment will improve the outcome of the patient, thus increasing the quality of life. In this case, an 8-year-old girl came with a status epilepticus accompanied by loss of consciousness as the main complaint. Before coming to Saiful Anwar, Department of Emergency, the patient also shows an indication of an immunocompromised condition based on anamnesis that is supported by patient history and clinical findings. When HIV infection were screened earlier, the dreadful opportunistic infection from this case wouldn't be happening. Even though the patient already in a very severe condition, proven by a very low CD4 plus titer and hemiparesis indicating a drop of neurological function, but a proper treatment with a need monitoring will still offer the best solution to overcome this condition. Based on this finding, it is suspected that the status epilepticus and loss of consciousness in the patient were caused by TB meningoencephalitis. Tuberculosis is the leading cause of death for patients infected by HIV, and in this case of terminal states of HIV, the focus of infection of Mycobacterium tuberculosis moves hematogenically to other organs, hence known as extrapulmonary tuberculosis. Some of the most usually encountered complaints on the patient experiencing meningoencephalitis TB are headache, neck rigidity, accompanied by a projectile vomiting as the effect of intracranial process. Those intracranial process are ranging in neurological deficit to coma. The decrease in consciousness is caused by a brain damage affecting the consciousness of the patient. The damage done by meningoencephalitis TB could also be caused by other infection targeting CNS, and in this case being toxoplasmosis proven by the cerebral abscess and laboratory findings. In this very case, the patient is experiencing both meningoencephalitis TB and cerebral toxoplasmosis. There is also a disorder involving the reduced lateral movement of the left apple, which suggests the 6th cranial nerve deficit. And based on this discussion above, to manage the emergency condition being status epilepticus accompanied by a decrease of consciousness, there needs to be management of seizure. After the emergency management is done, there needs to be the management of HIV. Based on the planning, there need to be 2 types of management, being management of HIV and management of opportunistic infection. There also needs to be prophylaxis initiation by using cotrimoxazole to prevent the infection of pneumocystis jirovecii in the patient. Other than that, the diagnosis of HIV, there needs to be a consideration to search opportunistic infection. If an opportunistic infection is found, the opportunistic infection needs to be treated first before initiating the ARV. So we're jumping to the conclusion. I described the uncommon case of the case and clinical evaluation, differential diagnosis, imaging workup, and treatment are addressed. What we can learn from this patient is that the prior diagnosis and excellent treatment holistically supported by patient obedience become a milestone in order to achieve a better prognosis, even in the worst condition. According to PET-KL examination, the patient's growth isn't experiencing any decrease in quality. Thank you very much for your attention. Assalamualaikum warahmatullahi wabarakatuh.